Okay, guys, hi. So let's begin today's lesson. Hope somebody else will join, but okay, just two people. Okay, so part two of the heart, we didn't finish that. It's going to be very quick because the difficult part was in the previous one. Um, Here on this particular slide, we're talking about the atrioventricular canal. How can we separate one atrium slash ventricle, right? Because they were opening into one another from each other. So this particular opening that you can see here, this is you're looking into the atrioventricular canal itself, right? So somewhere at the bottom of it, that's where the ventricle will be. Of course, as the last lesson you have learned, if you need to separate anything, endocardial cushions, right? So they have to be mesenchyme together with the neural crest cells, and these endocardial cushions have to fuse together. And when they fuse together, you now have not one but two atrioventricular canals. Unfortunately, this is a mistake in the book. They wrote that this is the superior endocardial and this is the inferior. No, this one is the anterior endocardial cushion and this one is the posterior one. So think about it this way. You had something like this, some kind of structure like this with a lumen. You had an atrium here and you have a ventricle here, right? So if you want to separate this common lumen, right? So again, ventricle is somewhere here. Atrium is a bit more anterior to it or more superior to it, right? And you want to separate this one common lumen into two. If heart is like this, of course you have the anterior endocardial cushion somewhere here and posterior is behind it. The person who was writing this book, one of them was responsible for text, one of them was responsible for pictures. So from this view, it may look like this one is the superior and this one is the inferior endocardial cushions. But you have to understand the 3D view of it, right? So this is a heart on a side almost, right? So it's like this. You're looking into the ventricle. Inside there at the back, that's where the ventricle is going to be. Atrium is a bit more anterior to it. So these cushions are not superior, inferior, because they're anatomically positioned like this. They are drawn like that, but anatomically positioning how's your heart. It's like this. So of course it's going to be the anterior and posterior endocardial cushions fusing together, and as a result creating some sort of septum. Here we're talking about the black thing that you can see here. That's the anterior posterior endocardial cushions. Okay, so just a different perspective from it, right? So somewhere here is going to be a common atrium, right? So there's going to be another atrium here, another ventricle. So this is the fusion point of the anterior posterior endocardial cushions. That's the part where they have fused together, right? So this, for example, could be the anterior endocardial cushion. Somewhere here could be the posterior, and they're fusing sort of in the middle and dividing your one common atrium, your one common atrioventricular canal into two. The purpose of this picture is to show you that the original ventricles, right? So you remember that the left ventricle came from the primitive ventricle of the heart tube, and the right ventricle came from the third of the bulbus cordis, right? It was trabeculated, it had pectinate muscles, so because it was part of the primary heart field. So you should know that originally the wall of these ventricles is extremely thick. It's heavily muscular, okay? So it has lots and lots of muscles in it. The problem with it is that if the wall of the original ventricles is very thick, it will contract with power as well. And if it contracts with power, it creates high blood pressure, and we do not want a high blood pressure in the embryo. So this wall, right, so this wall of the ventricle has to be somehow thinned out because it's too thick, too many muscles are present there. This is where the holes come in. Do you see? There's some kind of white holes present here and they become bigger and bigger. So basically, the idea is the following, that in the wall of your ventricles, in the muscular wall of your ventricles, apoptosis begins. Why does this apoptosis begin? Because it's too thick. If it is too thick, it contracts with much power, with much force, thus creating super high blood pressure. So apoptosis begins. So these white areas represent the cell death of the cardiac muscle in the wall of the ventricles. As I told you last lesson, what is responsible for shaping the way heart is? That's the blood, right? So as the blood flows in the heart, it shapes it the way that is the most convenient for it. So all of this apoptotic heart tissue is going to be washed away by the blood. And this is what we can see on picture C. Do you see that the wall of the ventricle became much thinner, right? So it's still muscular, still trabeculated, still has some pectinate muscles, but it is much thinner compared to where we started. And somehow certain muscles that didn't die, right? So for example, this region right here, it didn't become apoptotic. It kind of on the contrary. So due to the other muscles being removed from this region by the blood, it becomes even more prominent. So these prominent remnant muscles, they are known as the papillary muscles. So I do it again, right? So we started with normal primitive ventricles. Their wall is extra thick. We do not want that because it creates high blood pressure. So as a result, apoptosis begins. That's where the white color is, right? So that's the apoptosis of some of the cardiac muscle. We're trying to remove it. What is actually going to remove it? The flow in blood. As the blood comes in, it clears all of this apoptotic tissue away. As a result, the remnant muscles, the ones that didn't die, right? They become even more prominent. And those prominent remnant muscles of the ventricles, they are known as the papillary muscles. The black thing that we saw here, right? So let me erase it. The black thing that we saw here, this was the endocardial cushions, right? I told you that this is only one ventricle. There's another atrium here. You have to understand that we have already divided our heart into several things. So we have another atrium here, right? And we have another ventricle somewhere here as well. So this little black tissue right here, this is going to be your fused anterior posterior endocardial cushion. So this part right here is indicated on this picture as this part. Do you see? So it's the same thing, just from different views. So one is lying down, one is standing up. So these endocardial cushions consist of mesenchyme and neural crest cells. Some of these mesenchymal and neural crest cells, they start to come in and line the lumen of the ventricle. Do you see there is a black line, right? So this black line represents that from these endocardial cushions, some mesenchyme and neural crest cells have come in and they're lining the lumen of the ventricle. When ventricle's wall becomes apoptotic, right? So we're trying to remove some of the muscles. What's going to happen to this mesenchyme? Nothing. It stays as it is because it's not participating in contracting of the heart. So it stays as it is. It doesn't die. So these particular remnants of the mesenchyme that is lining the lumen, they will become the chorda tendineae, right? So they used to be, if you can take a closer look here, they used to line a certain piece of a muscle here. This muscle becomes apoptotic, right? It dies, but it's not removed because it is lined by the mesenchyme. So this kind of, I want to say, dead uh, remnant of this particular ventricular muscle lined by the mesenchyme, it stays as the chorda tendineae. Okay, so that's why they have a different consistency as the rest of the structures in the ventricle, right? You saw them, they were quite white in appearance because it was sort of like a dead muscle tissue that became a cord. So I repeat, it's not removed by the blood as the rest of the walls of the ventricle because it is lined by the mesenchyme. So mesenchyme kind of holds it in place. The rest of the endocardial cushions that we saw here, they will become the atrioventricular valves, right? So your bicuspid or tricuspid valves, depending in which ventricle you are located. A very weird question that they sometimes ask is this. Why, for example, in the right ventricle, we have 3 papillary muscles, and in the left, we have 2 papillary muscles, right? So why is that? The answer is very easy because it is based on the valves, right? So it's papillary muscles are attached to the chorda tendineae attached to the endocardial cushions that will become certain cusps of the valve. So basically, the amount of cusps in the valve that you have depend on the number of the papillary muscles. So if hypothetically I had 4 papillary muscles in the right ventricle, right? I'm going to have 4 cusps there in a valve. Usually that does not happen. Usually there is a pathological condition where tricuspid valve is not tricuspid but bicuspid. So a person have 2 bicuspid valves, right? So one in the left ventricle, one in the right. And the answer to that is because that person does not have 3 papillary muscles, he has 2 of them. So somehow the apoptosis was too much, right? So it removed so much of the wall of the ventricle that we didn't even get to have the 3rd papillary muscle there. Here we have additional endocardial cushions. Sometimes they're called swellings. Okay, so we call them conotruncal swellings, conotruncal cushions. They are present in the truncus arteriosum. Okay, so as you can see, this is the right atrioventricular canal, this is the left one. So that's the fused portion of the anteroposterior endocardial cushions, right? So when they have fused, they have divided your common atrioventricular canal into 2. So behind them, we can see some atria that are present here, and now we're in the ventricles, right? So we can see that now we're kind of in the ventricle part. So here, truncus arteriosum also possesses some kind of swellings, and the swellings or cushions are present in the most superior portion of it. There is a right conotruncal swelling or right conotruncal endocardial cushion, and of course there is the left one on the other side. So I repeat, they are present in the truncus arteriosum. And as you remember from the previous couple of lessons, truncus arteriosum is the outflow of the heart, right? So that's where the blood will be coming out from. So these swellings grow in the opposite direction. So left superior will be growing to the right inferior. Right superior swelling will be growing to the left inferior. So this picture is really trying to show you that we have the yellow and the, I don't know, purple color, violet, I don't know what this color is. So they're growing in the opposite directions. So do you see that there comes a point? So this point specifically right here, right? Where they meet up. So can you imagine that if I have like a right superior growing left inferior, it's growing this way, right? I have left superior growing downwards, right inferior. So if 2 of them are growing in the opposite direction, there comes a moment where they will meet up. And if they simply fuse like this, they completely obstruct the outflow, right? Can you imagine if they fuse like this? So they just meet up, they fuse, and that's it. They completely obstruct the outflow. This is a very fatal pathological malformation in the heart. It happens. So sometimes these endocardial cushions, when they grow towards each other, they just fuse. So what should they do? They should bypass each other. They should spiral and they will go in the opposite direction. So they would do something like this, right? So instead of just fusing together, they should spiral around one another. If they spiral around one another, as we can see on the picture B, a certain septum appears. It is known as the conotruncal septum. Another name for it is aorticopulmonary septum, which we have discussed when we talked about the blood vessels. You remember? In the aortic sac, there was aorticopulmonary septum. So conotruncal septum, as you can see on this picture, it has a spiral appearance because these two endocardial cushions are growing in the opposite direction. So they do not just fuse together, no, when they come in the proximity of one another, they spiral around one another and continue to grow in the opposite directions. This is why your aortic circulation and your pulmonary circulation is also spiraled. Think about your anatomy. Think about how aortic arch and pulmonary arteries are positioned according to one another. They have this particular twist to them, right? So I'm really trying to twist my arms here, but yeah, so they have a very particular twist to it. So this twist arises because of these endocardial cushions, because the way they have fused together, right? So they created this particular spiral appearance. It's very important to know a very particular pathological malformation. So we know that aortic circulation comes out from the left ventricle, right? And pulmonary circulation comes out from the right ventricle. In some people, this endocardial cushion septum is not spiral, but straight. So just straight like that. And if it is not spiral, if it is straight, what does it mean? It means that from the right ventricle, you're not going to have a pulmonary circulation, okay? You're going to have an aortic circulation from it. And from the left ventricle, you're going to have the pulmonary. Do you see this twist right here? So there is a red arrow, which is behind the septum, which is your left ventricle, right? Red arrow is behind the septum, which is a left ventricle. Blue arrow is in front of the part right here, right? Which is a right ventricle. So if this septum is not spiral, if it is straight, that means that this blue arrow will be behind the septum. And this red arrow will be in front of it, right? If it doesn't have this spiral appearance, if it simply is a straight septum, then you see that the two arrows, their origins will flip, because the reason that they're so spiraling is because of the spiral septum. But if it is straight, it will be flipped. Is it a norm, like, is it a viable situation? Of course not, right? Because you can imagine that the two circulations do not connect then. We'll talk about it right now. So this aorticopulmonary septum is very important for that particular reason. So the way it is positioned, the way it is formed, that it has the spiraling appearance, because of the spiraling appearance, the two circulations connect. The pulmonary and the aortic circulations, they have a connection between each other. Because I repeat, this is crucial, they always ask it. If this aorticopulmonary septum or conotruncal septum, the same name, if it is not spiral, if it is straight, the two circulations do not connect. We'll talk about it in a moment. Formation of the septum in the ventricles, very easy. So this muscular interventricular septum is the product of the bulboventricular sulcus that we talked about in the previous lesson. You remember? The primitive ventricle and the bulbus cordis, they had a particular junction between them. So this junction became bigger and bigger and bigger until it created the muscular part of the interventricular septum. So in a way, it is part of the primary heart field. So the interventricular septum is trabeculated, it's very muscular, the same as the rest of your ventricles. Now, the membranous part of the interventricular septum will come from here. Could you tell me what is this? So somewhere here we had anterior endocardial cushion. Somewhere here we have posterior endocardial cushion. And you remember I told you there is a point where they meet up, where they fuse together. So this right here is the fusion of the anterior posterior endocardial cushions. Because of this fusion, you now have two atrioventricular canals. If you didn't have this fusion, you would have one atrioventricular canal. So I go back to here. You started with this, which was a one atrioventricular canal. The two have fused together, right? So this is the anterior endocardial cushion. This is the posterior endocardial cushion. Now you have two atrioventricular canals. So how can I show this picture here? This is your anterior endocardial cushion. This is your posterior endocardial cushion. And in the yellow color, this is the fusion point. Because of this fusion point, you now have two atrioventricular canals. So because of this fused endocardial cushions, they send a septum as well. So the septum will be responsible for giving rise to the membranous part of the interventricular septum. Okay, so from this endocardial cushion, you're going to see that some kind of outgrowth or downgrowth is going to be formed. So also mesenchyme, neural crest cells, right, fuse with the muscular portion, and as a result, fully close down this septum. How do we make semilunar valves? Endocardial cushions. So just one word or two words. Some kind of outgrowths appear in the vessels, in the big vessels. What shapes semilunar valves? Blood, right? So every time the heart pumps, a little bit of blood will go back, right? So a little bit will go back, and as it goes back, it hits your endocardial cushions in a particular manner, creating semilunar valves. So blood is responsible for it. Tetralogy of the Fallot. Tetralogy of the Fallot is a very common malformation of the heart, specifically of the conotruncal region, right? So of the truncus arteriosum part. It's called tetralogy of the Fallot because four malformations must be present together at the same time, and only then you can call it tetralogy of the Fallot. So you cannot just choose one and say now this patient has tetralogy of the Fallot. So what are the four malformations? Number one, you're going to see that, let's do it in logical, because in the book it's a bit illogical, but let's do it in logical. Number one malformation, right ventricular hypertrophy, right? So hypertrophy means enlargement. So muscles here, the cardiac muscle in the right ventricle, are going to grow in size, not in number. Hypertrophy means in size. Hyperplasia means in number, and muscle can never undergo hyperplasia. It can only go hypertrophy, undergo hypertrophy. So cardiac muscle cells here increase in size, and this is known as the right ventricular hypertrophy. So of course you can understand that if it increased in size, that means that the right ventricle is now going to contract like no tomorrow, right? It's going to contract with lots of force, creating very high pressure. Because of this high pressure, you're going to see that the pulmonary vessels are now experiencing narrowing. This narrowing is called stenosis, right? So because of the pressure situation, here we're going to have a stenosis. In the pulmonary vessel, there's going to be narrowing, there's going to be stenosis. It's trying to what's the word I'm looking for? It's trying to kind of compensate for this hypertrophy by narrowing, okay? The third thing is that we have a ventricular septal defect. To be more specific, the membranous part is absent, right? So now there is a window of communication between the right ventricle and the left ventricle. So you can see that the muscular septum is still there because it was part of the bulboventricular sulcus, right? So it doesn't go anywhere. But this part, the top part of the septum, the membranous part, was formed when endocardial cushion has come down and fused with it, right? So that's how we form this membranous part. Well, you can clearly see that it is not present here. So membranous part is absent. Because it is absent, now the blood from the right ventricle can easily go to the left ventricle. And the last thing that we have is something which is called overriding aorta. Overriding aorta, it means that it overrides this effect right here, the septal defect. It overrides it. So it means that it can not only accept blood from the left ventricle, it can also accept blood from the right ventricle as well. So blood from the two ventricles will now go to the aorta, okay? So to this overriding aorta. Overriding aorta, another meaning for it is that it arises directly above this septal defect. Do you see? So that's where the window is present, which should not be there. And right above it, we have the aorta starting there. So that's what overriding means. Okay, but better explanation for sure is that it accepts blood from the two ventricles now, right? So it will go this way. Is it fatal? Not really. Okay, in embryo, fatal means that you die immediately. Okay, so that's what fatal means in embryo. This person can live up to age of 30, 35, maybe even 40. But because of the constant mixing of the blood, the organs are never fully exposed to the oxygenated blood. So they start to wear out. So this person will have a much shorter life expectancy because of the lack of fully oxygenated blood. So you can understand, right? So the blood will be mixing actively. So it's venous blood here coming back. And then here we have the normal, like arterial, so they will be constantly mixing. So that person will not die immediately, but if you don't fix these defects with surgery, the person will die eventually at the age of 30 to 35. Transposition of great vessels, this is another disorder or malformation that they're going to ask you. And we talked about it. So do you see, this is the spiral appearance. So this part right here, this is the spiral part of the aorticopulmonary septum. That's the part where the two endocardial cushions have kind of went around each other and created two outflows, right? We have the aortic outflow coming from the left ventricle, and we have the pulmonary outflow coming from the right ventricle. So this is a normal heart, right? So because that's how it should be. When the two endocardial cushions fuse together, they create this particular spiral appearance. In the transposition of the great vessels, do you see there is no spiraling? It's a straight septum. It doesn't have a spiral. It has a straight membrane appearance. So let's try to follow how does the circulation happen now. Because of this straight appearance, you can see that aorta now arises from the right ventricle. So let's follow its circulation. Right ventricle pushes the blood to aorta. Aorta pushes to the rest of the body. Body will give rise to veins. Veins return via the superior and inferior vena cava into the right atrium, back into the right ventricle. So this is one circle. Do you see? It's one circulation. What about left ventricle? Now you can see that the pulmonary artery arises from the left ventricle. So let's see, left ventricle, pulmonary artery, lungs, pulmonary veins, left atrium, left ventricle. So do you see the two circulations are independent of one another? Is this fatal? Absolutely, right? So the moment the child will take the first breath, all of this oxygenated blood will return back to the lungs. It doesn't go to the rest of the body, right? Because the aorticopulmonary septum is straight there. So as a result, the two circulations are fully disconnected from one another. So this one is fatal. Yeah. Okay. So baby needs to undergo immediate surgery, try to reconstruct the vessels. Okay. So it's a very, very dangerous situation here. So aorticopulmonary septum being spiral is a crucial moment in the circulation. Okay. Okay, so heart is finished. Let's go to the peritoneum, pericardium, and all of that. Now, the topic of peritoneum, you don't really have that topic anywhere. So this topic is not present in your embryo book, nor histo, nor anatomy. Okay, so development of peritoneum is nowhere to be found. Okay, I even took a look at some of the lectures and there were like 3-5 words present there. So yeah, so to be able to get this, I had to literally beg Short Zoli to do this for us. Okay, I had to beg him. He prepared these drawings for us, like he taught us for 15 minutes, and that's how I got this part of the topic. Okay, so that's what they want to hear. As far as I know, you must have it in the Gray's Anatomy. Okay, so there should be a little paragraph about development of the peritoneum, but if you're studying from other sources, you will not find it there. So let's take a look at how can we make the peritoneum. If you pick this topic in the embryology part of your exam, you have to draw. Okay, so make sure that you are able to draw some of these drawings to show. So peritoneum is the largest serous membrane, of course. It consists of the parietal and visceral layers, right? So parietal is always going to be on the body wall, and visceral is always going to be on the organ itself. What is the origin of the peritoneum? Of course, parietal layer will come from the parietal mesoderm of the lateral plate, right? So I go forward. Do you remember this? The V-shaped lateral plate, right? So this is the parietal mesoderm, and this is the visceral. After folding of the embryo, you can see that the gut tube is formed, and the most outer layer of the gut tube is the visceral mesoderm. Body wall is formed as well, and the inner layer of it is the parietal mesoderm. And what we have here, this is the body cavity itself. So what does it mean to be considered an intraperitoneal organ? We have to draw it. So let's draw it here somewhere. We're going to do a cross section. Okay, a cross section. So for example, a cross section through the stomach. We have posterior body wall. We have anterior body wall here. And somewhere here in the center, that's the organ of interest, right? So where is going to be the parietal mesoderm or parietal layer of peritoneum? Only on the body wall. Okay, so you do not even care where it is present. It is only going to be present on the body wall. That's it. To be considered an intraperitoneal organ, visceral mesoderm or visceral layer must fully surround the organ. Okay, your organ must be fully covered by it. If you see something like this, that there is a posterior body wall, there is the parietal layer here, and you see an organ sitting like this, right? And there is visceral mesoderm like this. This is not an intraperitoneal organ, this is a retroperitoneal organ. Why is it retroperitoneal? Because the back of it is free. Do you see? The back of the organ has no visceral mesoderm. Zero visceral mesoderm or visceral layer of peritoneum is present. So it is a retroperitoneal organ. If this organ was always like that, so from the moment it arises, it was like this, then this is, of course, primary retroperitoneal organ. If your organ was originally intraperitoneal and then something has happened and it was pushed out of the peritoneum, you call it secondary retroperitoneal organ, right? So for example, your colon is going to be a primary retroperitoneal organ, right? Kidneys are primary retroperitoneal organs. Pancreas is a secondary retroperitoneal organ, so is duodenum. So they used to be intra, but then something has happened and they became retro. So there is something, there's some terms that they always ask and they look for a very particular definition. We have to understand the difference between mesentery, peritoneal ligament, and omentum. As you know, there are two types of omenta. There is a greater omentum and there is a lesser omentum, and we have to talk about that as well. So what is mesentery? Mesentery is a two layers of peritoneum that is connecting organ to the body wall. Which two layers, to be more specific? It's always going to be visceral. So I repeat, parietal is only on the body wall. We don't care about it. Okay, we never see it pretty much. It's only on the body wall. We couldn't care less about it. So if this is my small intestine, for example, right? So this is a cross section of my small intestine. This is the visceral mesoderm that is fully located around my intestine, making it intraperitoneal organ. The rest of the visceral mesoderm that is connecting my small intestine to the posterior body wall, so this thing right here, this is known as the mesentery. So mesentery consists of two layers of the visceral peritoneum. Just don't forget that visceral peritoneum comes from visceral mesoderm. There are two types of mesenteries that could be present in the embryo. In the adult, there's only one type, but in embryo, there could be two types. There could be ventral mesentery, and there could be dorsal mesentery. Dorsal mesentery connects your organ to the posterior body wall. Ventral mesentery connects your organ to the anterior body wall. And this picture right here is very crucial. What we can see here, this is your entire gut tube. Do you see? So here we have a bit of the esophagus, stomach, duodenum, small intestine, large intestine, and then the rectum, right? Somewhere here, you're expecting to see anterior body wall. So this part right here, this is your anterior body wall. At the back, somewhere here, this is your posterior body wall. And I really want you to see that stomach is the only one in embryo that has connections to both. Do you see? There is a dash lines here that is connecting stomach to the posterior body wall. And there is a dash line here, which is connecting stomach to the anterior body wall. So of course, these are mesenteries. So this picture right here, right? So what we have drawn here, this is your small intestine with the visceral layer around it. Small intestine is not an exception. Do you see? It only has posterior or dorsal mesentery. So how do we draw a small intestine? Well, if this is my anterior body wall, this is going to be the parietal layer that is fully closed. And your visceral mesoderm kind of goes around your small intestine and connects it to the posterior body wall. So this part right here, this is going to be mesentery proper, what we call, right? Because this is the dorsal mesentery of the small intestine. It is connecting your stomach, your small intestine to the posterior body wall. If I want to draw the same picture, but I want to draw it for the stomach, right? So how would the stomach look like in the same cross section? So again, of course, you draw the posterior body wall. you draw the anterior body wall. There is a parietal layer that is on that body walls. This is parietal layer of the mesoderm or peritoneum. And somewhere in the center, this is a cross section of your stomach. Stomach is an intraperitoneal organ as well, because we can see that visceral mesoderm fully surrounds it from every side, right? So this picture, these lines right here, they represent the visceral mesoderm. I really hope that you understand that when I say visceral mesoderm, I also mean visceral layer of peritoneum, because it's the same thing, right? So stomach, this is the visceral mesoderm. But stomach is the exception, do you see? It doesn't only have connection to the posterior body wall, so it doesn't only have the dorsal mesentery, it also has the ventral mesentery that connects your stomach to the anterior body wall. These mesenteries have names, of course. The anterior one is known as the ventral mesogastrium. Okay, so it connects stomach to the anterior body wall. And there is a dorsal mesogastrium that connects stomach to the posterior body wall. Keep in mind that you do not have these structures in you. Is there such a thing in the adult that is dorsal mesogastrium? Of course not. Is there ventral mesogastrium? Of course not. So they must become something in the adult. Embryo, however, has these stomach mesenteries, and they, I repeat, are called ventral mesogastrium and dorsal mesogastrium. So this picture shows you all the mesenteries in the gut tube, right? So this is your stomach. As you can see, stomach is the exception. It has a mesentery that connects to the anterior body wall and to the posterior body wall, ventral, dorsal, mesogastrium. Duodenum is no exception. There is only one mesentery that connects it to the posterior body wall. It is known as the mesoduodenum. Small intestine, no exception. Mesentery connecting to the posterior body wall, mesentery proper. Large intestine, dorsal mesocolon. Okay, so yeah. So what is needed here? Mesoduodenum will disappear very soon. So majority of the mesoduodenum will be gone, making your duodenum a secondary retroperitoneal organ. That it had mesentery, right? It had mesoduodenum, but then this mesoduodenum has disappeared. There's only one part where mesoduodenum does not disappear. There's only one part where duodenum is intraperitoneal organ. And you know this in the anatomy, right? So the first couple of centimeters of duodenum are intraperitoneal. So sometimes they ask you, how do you call the mesentery of the intraperitoneal duodenum? In Latin, it's called ansa duodenalis. Okay, so this little tiny part, let me try to indicate it. This is the only remnant of the mesoduodenum. It's in the first part of your duodenum. It's called ansa duodenalis, or loop of the duodenum. And it is a mesentery, so it has two layers of the visceral mesoderm, or visceral layer of peritoneum, connecting your upper duodenum to the posterior body wall. In mesentery proper, this is English name. In Latin, they call it ansa umbilicalis. Sometimes they ask this as well. Okay, so Latin, they call it ansa umbilicalis. What is peritoneal ligament? So we understood what is mesentery, right? In the anatomy, you know that. What is the purpose of this mesentery? To allow blood vessels, nerves, and lymphatics to enter, right? So that's the only way blood vessels, nerves, lymphatic vessels can enter into an organ, if they actually pass through the mesentery. What about peritoneal ligament? What is that? Peritoneal ligament is also consisting of two layers of peritoneum. So two layers of visceral peritoneum, but it is connecting organ to organ. We're going to see right now. So could you tell me, how do we call this?
Ventral mesogastrium.
Perfect. And this one is? Dorsal mesogastrium. We're going to see that within the ventral mesogastrium, liver will be developing. Within the dorsal mesogastrium, spleen will be developing. So because of these two organs, the ventral and dorsal mesogastrium, they will be disrupted. They will become something else. Okay, so because of the growth of these two organs. So if liver is here, right? So liver is here developing, spleen is here developing. Do you see that there's still a part of the two layers of visceral mesoderm that connects stomach to the spleen? So this is peritoneal ligament. And to be more specific, this is the hepatogastric, right? Because it is connecting between stomach and liver. If this is your spleen, you can see that there is still visceral mesoderm. And this visceral mesoderm has two layers, right? 1, 2. And it is connecting your stomach to the spleen. So this is your gastrosplenic ligament. So peritoneal ligament and mesentery are pretty much identical structures. The only difference between them is what are they connecting, right? Peritoneal ligament will connect organ to organ, also consist of two layers of visceral mesoderm. Mesentery will connect organ to body wall. And lastly, we reach omentum. And I guess this is the most important question out of the whole thing today. What is omentum? And the key word that you must say that it is a fold of peritoneum. So you have two types of omenta. You have the true omentum and you have the false one, the pseudo. Greater omentum is the true omentum because it is a fold, right? It's like an apron that is coming down. So here it is. So this is your greater omentum right here. So like a fold coming down. The lesser omentum is a false omentum because it doesn't fold. So if it is a fold of the peritoneum, how many layers of visceral would there be if it is a fold?
4.
4. So really try to understand that we started with 2 layers of something, right? It came down and then it folded back. So if you count, right? If you count visceral, 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 visceral. Lots of students make mistakes saying that the outer are parietal and the inner are visceral. It's not how it goes, okay? The entire omentum consists of visceral peritoneum, visceral mesoderm. Forget parietal, it's only on the body wall. We don't care about it, right? So omentum, the true omentum would look like this. And this is your greater omentum. It has 4 layers of visceral peritoneum. Lesser omentum is considered to be false omentum because it does have 4 layers. And they go kind of like this. I will try to draw it because they go, one is on the top of it and one is under it. So the dashed line should show you that it is under it. So what am I drawing here? This is lesser omentum. What is the top thing?
Visceral.
Lesser omentum, what does it consist of? Lesser omentum consists of 2 peritoneal ligaments. The top peritoneal ligament that go like this, 2 layers of visceral, is hepatogastric ligament. The bottom of the lesser omentum, which is going like this, also 2 layers, this is the hepatoduodenal ligament. So if you do the math, you can see that there are 2 layers of hepatogastric, from the hepato to the gastric, and there are 2 layers of hepato to duodenal. Together, they are 4 layers. So that's why it's called omentum. But it is not true omentum, because even though it is 4 layers technically that are close to one another, it doesn't fold. So this is a crucial question that they really ask sometimes to see if you understand the omentum. So omentum, to be considered omentum, you have to fold back, right? So from the stomach to the transverse colon right here. So this is going to be the greater omentum, true fold of 4 layers. Lesser omentum consists of 2 ligaments, hepatogastric and hepatoduodenal ligaments. And each ligament we know is 2 layers of peritoneum. So do the math. If there are 2 ligaments next to each other, how many layers of peritoneum is there? 4 layers of visceral peritoneum. So that is a lesser omentum. That is a false omentum. I repeat, because it doesn't fold. There is no folding. There are just 4 layers of visceral peritoneum. Okay, what's gonna happen next? This picture, let me erase this part. This picture is a cross section, very similar to what we have drawn here previously. You remember there was a stomach with the 2 mesenteries like this, right? Attaching to the posterior body wall and to the anterior body wall. So blue color, this is a visceral mesoderm, and purple color, this is a parietal mesoderm. Okay, so this is going to be your 2 lateral body walls somewhere here. This is the anterior body wall, and this is going to be the posterior body wall right here, right? So anterior, posterior body wall and 2 laterals. This is your stomach in the center. So how would you call this entire region? Do you see? Somebody is growing here in that region. So what is this?
Ventral mesogastrium.
Perfect. This is a ventral mesogastrium. How would you call this region that is behind the stomach, right? Attaching stomach to the posterior body wall, spleen is developing here. This is dorsal mesogastrium. What happens next? We are going to talk about it next lesson, but stomach rotates a lot. It starts in a certain position, but then it is going to be rotating. And the first rotation that we can see here, this is known as the 90 degrees longitudinal rotation. So I always like to show this as a pen, okay? Especially, just a sec. Especially if you have a pen with this little tiny thing, okay, like with this tiny thing. I really like to show how the stomach rotates with that. So originally, we're gonna learn this next lesson, stomach is just a tube like that. So this is your stomach right here in your embryo's body, just a normal tube. This thing right here represents the original left side of the embryo, of the stomach of the embryo. Okay, so this little thing that you can see here, this is the left side of the stomach of the embryo. What did we say? What is the first rotation of the stomach? It is 90 degrees clockwise. So do it. And if you do 90 degrees clockwise, you can notice, let's do this a little bit close up, right? So this is the left side, right? This is the left side of the stomach. If you do 90 degrees clockwise, where does it become? Where does it appear? It appears anteriorly. It's looking right at you right now. It becomes anterior. What is the innervation of the vagus, of the stomach? Left vagus innervates anterior surface of the stomach. Right vagus innervates posterior surface of the stomach. And they always ask why. Well, now you know why, because of the 90 degrees clockwise rotation. If your stomach rotates, take a look, left side, the original left side, after rotation becomes anterior. Original right side, because of rotation, becomes posterior. So because of this 90 degrees clockwise rotation, right, like a clock, 90 degrees clockwise rotation, left vagus moves a bit anteriorly and starts to innervate anterior surface of the stomach. And right vagus moves a bit posteriorly and starts to innervate posterior surface of the stomach. So this is what we can see here. So could you tell me if this is your original position of the stomach, right? Like this, because we can still see that this is on the left side, right? It's not anterior, it's on the left. This is on the left. What is connecting stomach to the posterior body wall? My finger. What is connecting stomach to the posterior body wall? Dorsal mesogastrium. And what is connecting stomach to the anterior body wall like this? Ventral mesogastrium. So because of the rotation, right, we move 90 degrees clockwise. Where does dorsal mesogastrium end up? So this is original left side. This is original right side. Do a 90 degrees clockwise rotation, right? So rotate this way, anteriorly, 90 degrees clockwise. Dorsal mesogastrium is originally located posteriorly because it is attaching stomach to the posterior body wall. But because of the 90 degrees clockwise rotation, dorsal mesogastrium ends up on the left side. On the left side. Ventral mesogastrium attaches your stomach to the anterior body wall. Do the movement, do the 90 degrees clockwise movement. The ventral mesogastrium will end up on the right side. And this is what we can see on this picture. So this part right here, this is your ventral mesogastrium, and this is your dorsal mesogastrium. And we can see that ventral mesogastrium ends up on the right side, hence liver is on the right. Spleen, which is in dorsal mesogastrium, ends up on the left side, right? So if they ask you, why is the position like that? Why is the stomach in the center, spleen is on the left, liver is on the right? The answer is very simple. All of it is because of the rotation of the stomach, because of the 90 degrees rotation of the stomach. Really do practice it at home to do it. It's very easy. Just take a pen with the little thing, okay, on the side. Say that this little thing is the left side, original left side, and do 90 degrees clockwise rotation. The clock is like this, right? The problem that we're in a camera, so it's the opposite right now for you, okay? So, but yeah, so do 90 degrees clockwise rotation, left side will become anterior. Very good mnemonic, LARP, left anterior, right posterior. So that's the product of the 90 degrees rotation of the stomach. What do we have here? A little bit later, we have discussed that this is your ventral mesogastrium. This is your dorsal mesogastrium. This is the stomach in the center, right? Liver is developing in the ventral mesogastrium, fine. Spleen is in the dorsal, but a bit later you can see that somebody else is joining the party, which is the pancreas. Okay, so pancreas is going to be for a short period of time. It is going to be present within the dorsal mesogastrium. And this is the final result. Okay, so this is the final product, the final result. Is there pancreas there? No more. Okay, so it's not there anymore. Why? What has happened? What has happened is the second rotation of the stomach, which is known as the antero-posterior rotation. How is the stomach located in you? It is definitely not standing straight like this. Okay, stomach is laying. And this is the antero-posterior rotation. If your stomach is a tube like this, right, you can see that this part is now anteriorly located, right? It's looking right at you, it's anteriorly. The second rotation is the following. This is the pyloric part of the stomach. This is esophageal. The antero-posterior rotation goes like this. Pyloric part moves to the right and upward. So I repeat, it moves to the right and upward. And as you can see, now this is position of the stomach. It's literally laying in your body like this, that pyloric part is a bit more anterior. That's the body of the stomach, and esophageal part is a bit more posterior. Okay, it's somewhere at the back in your body. Okay, so as you know, trachea is a bit more anterior, right? Esophagus is a bit more posterior. So that's the proper way for the stomach to lie down. So instead of standing like a tube in embryo, after antero-posterior rotation, it assumes its normal position, which is laying down like this. The problem is that liver helps this antero-posterior rotation. So this is your stomach right here. This is your liver on the side of it, right? Within the ventral mesogastrium, which is now on the right side. Ventral mesogastrium is on the right. That's where the liver is located. Liver is a crucial organ in embryo. We allow it to do whatever it wants to do. It wants to expand 10 times fold, let it. Because it is a hematopoietic organ, it is responsible for making blood. If it wants to do what it wants to do, let it. So, stomach is a tube. Liver is right here. As the stomach rotates the antero-posterior rotation, as it assumes its laying down position, liver pushes even more, okay? It expands even more. So that way, stomach starts to push on the organ right next to it. What is the organ right next to it, which is a bit behind?
Pancreas.
Spleen.
Spleen.
What was right next to the spleen? Originally, what was here? Pancreas. And what was next to the pancreas? A body wall. So, as your stomach assumes the lying position, liver is expanding that way, right? It pushes all of the things that way. Who is going to suffer the most? Pancreas. Because it is facing the body wall, there's nowhere to go. So what does a pancreas do? It slips out of it. It's very slippery in your body wall. It slips out of the dorsal mesogastrium, okay? It slips out of it. The only thing that is trapped in the dorsal mesogastrium of the pancreas is its tail, right? It gets trapped in the hilum of the spleen because now as the liver pushes all of the organs to the left side, spleen becomes the one that is facing the body wall. Pancreas has slipped down a little bit, but the tail got trapped in the hilum of the spleen, making that part of the pancreas intraperitoneal, right? So tail of the pancreas is intraperitoneal. So that's how your pancreas becomes a retroperitoneal organ, okay? That it only has it on the anterior surface, not everywhere. So I hope that was understandable. So due to the antero-posterior rotation, due to the growth of the liver is pushing all of the organs to the left side. Behind the stomach is the spleen right here. Next to the spleen is the pancreas. Here we have a body wall. If you expand towards the left side, you're pushing all of the organs towards the body wall. Very slippery is in our body. You've seen it in the anatomy, in the cadaver. All of the organs are very slippery. So pancreas just slips out of the dorsal mesogastrium. Only the tail is going to stay there. So this is a crucial to know in the anatomy as well as in the embryo. Okay, so what happens to the dorsal mesogastrium and what happens to the ventral mesogastrium? Okay, so what is going to be happening to them? Ventral mesogastrium will become hepatogastric ligament. We have it here. Okay, so let me show it like this. This is ventral mesogastrium right here. This. Of course, everything in blue, right? The purple we don't touch. It's the parietal layer. So hepatogastric ligament. Hepatoduodenal ligament. We can't see it, but it's a bit under here. Okay, so hepatoduodenal ligament. Falciform ligament and hepatorenal ligament. All of these are products of the ventral mesogastrium. So if in the anatomy they ask you, how did the falciform ligament appear? It's a remnant of the ventral mesogastrium. How did the lesser omentum appear? It's the remnant of the ventral mesogastrium. That's the only thing you need to say. Dorsal mesogastrium is very interesting because it kind of splits. It splits into two. Its superior surface will become the ligaments, the gastrosplenic ligament and phrenicolenal ligament, the ligament between the diaphragm and the spleen. But the inferior surface of the dorsal mesogastrium will become greater omentum. So how does it happen? And I really want you to pay attention to for a sec here. Okay, if they ask you, how did you form a greater omentum? Oh, this is your stomach. This is dorsal mesogastrium, my finger is the dorsal mesogastrium, the inferior surface of the dorsal mesogastrium, because superior is just ligaments, right? The gastrosplenic, phrenicolinal, that's it. But the inferior one, something happens to it. What am I showing here? What is this? What is stomach doing here if I do it like this?
Anterior-posterior rotation.
Perfect. This is the anterior-posterior rotation. Who pushes more this way?
Liver.
Liver.
Liver. So this is dorsal mesogastrium. What happens is this. Do you understand? Dorsal mesogastrium is folding. Do you see? It's folding downwards. And as it folds downwards, it becomes this greater amentum. So visceral, 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 visceral. Very difficult to visualize it, but that's what happens. That's the theory. Okay, so because there's too much pressure here on the left side, dorsal mesogastrium has no place, right? Pancreas even escaped because it couldn't handle all of the pressure that the liver was putting. So when liver pushes, when it expands, when anteroposterior rotation happens, dorsal mesogastrium, I repeat, only the inferior surface, the most bottom of it, under the pressure, it has nowhere to go. So it literally goes like a balloon downwards. It falls, right? Your stomach lies down, so does the dorsal mesogastrium, right? It is attached to the greater amentum part a little bit, and it is going downwards like a fold. Do you see? My finger has folded, right? It was straight, but then it folded. Straight, but then it folded. So this is the greater amentum. Okay, so it folded under the pressure. That's the theory that they want to hear. Okay, moving on. Body cavity, we talked about an embryo one. You remember that this is your somatopleur, this is your splanchnopleur, right? So ectoderm with the parietal mesoderm, visceral mesoderm with the endoderm, right? So we talked about it. Which one is fusing to make a body wall? Of course, the somatopleurs. Do not forget that this picture is the cross section through which region? You have a gut tube, and gut tube has 3 regions. So this section is the cutting through which regions? What is this called? This is known as the vitelline duct. And vitelline duct is the one that connects midgut to the yolk sac. Okay, so on our first lesson, when we did a revision of the embryo one, I told you that because of the folding of the embryo, yolk sac does not allow the folding to happen properly in the mid region of the embryo. In the foregut region, so in the cephalic region, and in the hindgut region, in the pelvis, there is no yolk sac. So the 2 somatopleurs fuse normally, and your endoderm is folded into a gut tube, which is normal. But in the midgut region, in the middle, the 2 somatopleurs cannot fold together because yolk sac is still there. And this is approximately 4th to 5th week, and your yolk sac is still a hematopoietic organ. We can't just cut it off. Okay, so it stays as it is. So there is still a connection between the midgut and the yolk sac via the vitelline duct. Okay, serous membranes, everything we know here, okay, it's what we talked about, the parietal, the visceral, okay, we're reaching the point of a septum transversum. So septum transversum is going to be this thick brick of mesoderm. It is visceral mesoderm, okay, so it is a visceral mesoderm, And the purpose of the septum transversum is to divide your newly formed cavity, right? So you have just formed this cavity right here, thanks to the fusion of the somatopleures. So the purpose of this septum transversum is to divide your newly formed cavity into the thoracic and abdominal. And this is what we can see on this picture, right? This is your vitelline duct right here. This is your yolk sac somewhere here. So you're in the mid-gut region. This is the hindgut region. This is the foregut region. So we can see that there is a very thick brick of mesoderm, which is known as the septum transversum, right? It is proliferation of the visceral mesoderm. And the purpose of it is to divide your newly formed body cavity into two. So everything above it is the thoracic cavity. Everything below it is the abdominal body cavity. Septum transversum is also very important because for a short period of time, liver will be growing next to it. In this picture, they show it as it is inside of it. It's not inside of it, it's under it. Okay, so it's a bit under it. So septum transversum is a bit above the growing liver. So they will be touching for a short period of time. So here we have a cross section of our embryo, and some things are important to see. Of course, here we have our heart tube. Okay, so this is a heart tube. This part right here, this is a visceral mesoderm. Because you remember that it was growing in the visceral mesoderm for a short period of time, the heart itself. So this is a visceral mesoderm. What is this?
Neural tube.
Neural tube. So this is the back of the embryo. Black dot is, of course, the notochord. This pink structure is the dorsal aorta. Remember, we will have a single dorsal aorta because majority of the right one will disappear, so eventually there'll only be one dorsal aorta. Yellow thing that you can see here, this is a gut tube. This is, to be more specific, this is the foregut. And extensions of the foregut are the two lung buds. We're going to talk about it, I think, today. Okay, so the two lung buds are going to be growing out of the endodermal foregut. On this picture, we have to understand where is the visceral mesoderm and where is the parietal mesoderm. So I'm going to outline the parietal mesoderm. So everything that you can see here, this is the parietal mesoderm. The mesoderm that you can see on the lungs itself, this is, of course, visceral. Okay, so this is the visceral mesoderm right here. You can see that there is a fold that is formed, which is known as the pleuropericardial fold, right? It's present right here. Pleuropericardial fold is a thickening of the parietal mesoderm. It's some kind of proliferation of parietal mesoderm. The purpose of these folds is to create pleural and pericardial cavities. So what we're trying to do on this picture, we're trying to separate the thoracic cavity into two, into the pleural cavities and into the pericardial cavities. This little, let me erase it so I can do it properly. These little tiny things that you can see here, these are lung buds. They aren't mature lungs. They aren't made. The lung buds that are growing here are going to be expanding first laterally. They're going to expand this way at first, laterally. And after that, they're going to expand anteriorly. They're going to expand this way. So these arrows indicate the way these lung buds will grow. They're going to grow first laterally and then anteriorly. So if I show you the next picture, this is the end product. Do you see picture C? So this is my foregut. These are my lung buds, and do you see they have finished growing? So where are they located? A bit more anteriorly to the heart, right? So they kind of fully wrap around the heart. So we have pleuropericardial folds that are present here. Let me erase this part. We have pleuropericardial folds. They are extensions of the parietal mesoderm. Lung buds start to grow laterally. As they grow laterally, they grow into this fold. They grow into this area right here. So as they grow into this part, they slowly start to modify the shape of this fold. Can you imagine the lung is expanding into it? So as it expands into it, it slowly starts to peel off this pleuropericardial fold. So take a look at this picture. Do you see how pleuropericardial fold is located here? And take a look at this picture. Do you see now there is a gap present here? Why is there a gap present here? Because the lung is expanding laterally, right? It is expanding laterally. If I have to show with my hands, this is your body wall right here. This is your pleuropericardial fold, this one. This is pleuropericardial fold. This is the body wall, right? As we can see on this picture right here. The same thing. So body wall, pleuropericardial fold. Who is going to be expanding into here? Lung. And as it expands, it does something like this. Okay, it's kind of detaching the rest of your fold from the wall, right? So it's kind of pushing the fold away from the body wall, Because of the growth of the lung, pleuropericardial fold becomes pleuropericardial membrane. It is now becoming much thinner. What are these two pleuropericardial membranes are going to do? Of course, they're going to fuse together. So these two pleuropericardial membranes are part of the parietal mesoderm. Because they're part of the parietal mesoderm, they are responsible for giving rise to the parietal layer of the pleura together to the fibrous pericardium. As you know, that's the parietal layer, right? The visceral pericardium is this part right here. It's the visceral mesoderm. So fibrous pericardium will be this region together with the parietal layer of the pleura. So when these two membranes fuse together, there is no more connection between pleural and pericardial cavity. Now your thoracic cavity is fully divided into pleural and pericardial. So the most important thing to remember is that pleuropericardial folds are a product of parietal mesoderm, right? So they aren't visceral, they're parietal, they're extension of the parietal part of the body wall. They fuse together, create this full, what's the word I'm looking for? Creating this full border between the lungs and the heart. Two things are present inside of the pleuropericardial folds and membrane. We have the common cardinal veins and we have the phrenic nerves. As you know, anatomically, in the adult, phrenic nerves are located laterally to the heart, right? So they're located on the lateral surface of the heart. But originally, phrenic nerves are located posteriorly to the heart, okay? So they're behind the heart. A question that they're going to ask you here is what happened? So how come from the posterior surface they move to the lateral? Who is responsible for this? Of course, your lungs. As the lungs expand, they push your phrenic nerves to the lateral surface. Diaphragm. If you take a look at this picture right here, so this is your septum transversum. Septum transversum was a thick brick of a visceral mesoderm, and it was dividing your body cavity into two. So everything above was thoracic, everything below is abdominal. So who does the same thing in you? Of course, diaphragm, right? So diaphragm does the same thing in your body. It divides your one whole body cavity into thoracic and into the abdominal body cavity. There is a communication, however. So in embryo, there is a canal that is known as the pericardio-peritoneal canal. And you can see that it is a space between septum transversum and posterior body wall. This space should be closed. And this is what we can see on this picture, right? So this is your septum transversum. This is your posterior body wall. And this is pericardio-peritoneal canal that we just saw previously. So this canal should be closed, because if you look at your diaphragm has no openings there, like no big gaps that are present. So this canal should be closed. We have something which is known as the pleuroperitoneal fold. Pleuroperitoneal fold is the extension of the lateral of the parietal mesoderm, because it is located on the lateral border of your body, right? So this is a parietal mesoderm. What's going to happen? These two pleuroperitoneal folds are going to fuse together with the septum transversum, fully closing the connection between thoracic and abdominal body cavity. But you must remember that your diaphragm is a muscular structure, and the innervation of the diaphragm is phrenic. And phrenic, right? So phrenic nerve comes from C3, C5. So you must remember that to be able to make it properly like a diaphragm, myotomes, you remember paraxial mesoderm? It has somites, right? It has sclerotome, dermatome, myotome. So myotomes, specifically from C3, C5, will migrate here and be responsible for the skeletal muscle of the diaphragm. So nobody knows why, okay, but there is a theory that this septum transversum that you see here, in embryo, it's higher. It's not at the level of your diaphragm, okay? It's a bit higher. So this is why C3, C5s migrate here and give rise to the muscle of the diaphragm, to the skeletal part. And then later, because heart is going to be right on the top of it, right? Later, when the heart descends, it pushes down your entire septum transversum. As a result, all of your arteries and nerves are elongating here as well. Okay, so that's kind of the explanation. But remember that the innervation of the diaphragm is C3, C5. So the only thing that it means that the myotomes from C3 to C5 have come here and innervated this part. Some kind of malformation that we have here, hernia. Okay, so we have congenital diaphragmatic hernia, so something that you are born with. It's a very common malformation, and it is a failure of pleuroperitoneal folds to close pericardio-peritoneal canals. To simplify, it stays like this. No fusion happens. So you will have a diaphragmatic hernia, congenital one, if these folds do not fuse with septum transversum, they stay open. Two types of hernia could be present. There is a parasternal hernia and there is an esophageal hernia. Parasternal hernia arises when we see some kind of parts of the peritoneum present behind the sternum. So maybe intestinal loops. Sometimes even a part of the liver, a part of the spleen can be present behind the sternum. Unfortunately, it is overall fatal. It has a very high rate of mortality because if a part of the peritoneum is present behind the sternum, there is no place for the lungs to develop. So as a result, lungs become very small, okay, very small. so small that when the baby is born, it's not enough to breathe. Okay, so the baby will suffocate. So unfortunately, this parasternal hernia is a bit bad one. If it makes any sense. Okay, so it does have a high mortality, not directly as an effect, right, of the hernia, but rather as a side effect, because if these organs are present inside of the thoracic cavity, lungs have no way of growing properly. They become hypoplastic. Okay, you remember that plasia means number of cells, not size, but plasia. Not trophy, right? Like hypertrophy that we saw in the right ventricle, but that was the size of a cell. Plasia means number of cells. So they become hypoplastic, the lungs. There aren't that many alveoli that are present there. Esophageal hernia, it could be congenital, it could be not congenital. Pregnant ladies, men are very susceptible to esophageal hernia. In the esophageal hernia, a part of the stomach protrudes through the esophageal opening, because you know that in the diaphragm we have the opening for the esophagus, and through that, the part of the stomach, the cardia, usually herniates. So it could be congenital, but it could be not congenital due to high pressure, like obesity or pregnancy. Sometimes you could have this hernia. So it's not fatal. Just you're gonna have like a heartburn, right? So constant feeling of acidity. And yeah, okay, so I think that's it. Okay, guys, let's go for the respiratory. It's the last thing for today. It's very quick. Very good topic. Okay. The entire respiratory tract develops during the 4th week, and it develops as the diverticulum or outgrowth of the foregut. So take a look at this picture right here, right? So this little thing that we can see here, this is a part of the septum transversum, right? We can see that liver is growing in the, like a little bit in the septum transversum. Heart is on the top of it. We just said that septum transversum participates in making diaphragm, right? So don't forget that. So little blue thing, this is the outgrowth of the endoderm of the foregut, from which the entire respiratory system is going to arise from. Do not forget that outside of it, there would be a visceral mesoderm as well, right? So right on the surface of the respiratory diverticulum, there would be a visceral mesoderm. The question that they usually ask is why here? Because the rest of the gut tube is also endoderm, right? Midgut is also endoderm, and so is hindgut. So why respiratory diverticulum, the lung bud, develops from the foregut specifically? TBX4 is expressed here, okay? So this is a transcription factor which is responsible for the respiratory diverticulum. So specifically here, TBX4 is expressed, and because of this TBX4, the entire respiratory system will be arising from that part of the endoderm of the foregut. Why is TBX4 expressed here? Because of the retinoic acid. You need to remember that naturally retinoic acid, its highest concentration is in the head region, in the cephalic region, and the lowest concentration is in the tail region. The highest concentration in the tail is going to be FGF8, fibroblast growth factor 8. So it's the highest in the tail, and it's the lowest in the head. So this creates some sort of pattern, some sort of patterning of organs. Like that explains why some organs are present in the cephalic region, while some are in the caudal. So they did experiment, they artificially switched it up, right? So they put retinoic acid in the hindgut region, super high, and guess what? Retinoic acid, because retinoic acid became super high in the tail region, TBX4 got expressed here, respiratory diverticulum started growing in the hindgut region. So basically, you could breathe out of your regions. Okay, so yeah, so the explanation for this is retinoic acid and TBX4 that naturally they accumulate in this region. So that's where respiratory diverticulum arises. When respiratory diverticulum arises from the endoderm of the foregut, originally the two lumens are connected. So we can see that this is the lumen of the foregut and this is the lumen of the respiratory diverticulum. Of course, this is not what you want. You don't want your digestive system and respiratory system to have a common orifice. You want to separate them. You do that with the help of the tracheo-esophageal ridges. So very similar to heart's endocardial cushions, very similar. You had one lumen, right? This was the foregut, this was the respiratory diverticulum. You had one lumen. You want to separate this one lumen into two. Tracheo-esophageal ridges appear, fuse together, and then fully detach from one another, creating the foregut and the respiratory diverticulum lumen, right? So they have to fuse together, create a septum, tracheoesophageal septum, and the septum is responsible for fully separating the two systems. Something can go wrong, however, with the septum, and they want you to notice there is something which is known as the atresia and fistula. Fistula, usually tracheoesophageal fistula, of course, is simply a connection between the two organs, between the trachea and esophagus. Okay, so a communication of some sort, a part where they have a common lumen. That's what fistula is. They have a common lumen there. Atresia means that it is discontinuous. Do you see? So like here we have esophageal atresia because there is a little bit of it present here and then it detaches from the rest of the esophagus. The same here, right? So there's a bit of it present here and then it detaches from the rest of it. So these diseases, right? So not diseases, these malformations, the atresia and fistula are product of failure of this one, that the ridges don't form the proper septum and don't fully detach, that in some parts it still have connections to one another. So it's still connected to the esophagus, or esophagus still connected to trachea, and etc. So please know the difference between fistula and atresia, right? Fistula is the connection, communication. Atresia is simply miscontinuation, that it doesn't continue as one. It's a very discontinuous organ. Now, once the respiratory diverticulum fully detached from the foregut, you're going to see it starts to form two outgrowths. Those two outgrowths are going to be known as the lung bud. And of course, these lung buds will become primary main bronchi. Okay, so these are the primary main bronchi. Later, you're going to see that these two lung buds that we have here, right, so the primary main bronchi, start to divide a bit more. So here we're going to have the two different, how do you call these ones? That's the lobar bronchi or secondary bronchi, and you can see that there are 3 and 2, right? So on the right side, we're going to have 3 secondary lobar bronchi, and on the left side, we're going to have 2 of them. These secondary lobar bronchi continue to divide a bit more. So we can see that there are how many? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So in the right lung, right, these secondary lobar bronchi divide to become 10 bronchopulmonary segments or 10 tertiary bronchi. In the left side, according to embryo, there are 8, but according to anatomy, there are 10 as well. And you remember that how they are positions, right? So in the upper lobe of the right, we have 3, middle 2, lower 5. 3, 2, 5. In the left lobe, we have 5, 5. So in the upper left, 5, in the lower left, 5, or according to anatomy, 3, 5. Okay, so that's the part that is important. These tertiary bronchopulmonary segments, of course, continue to divide, right? So they will become the transitional bronchiole, then terminal bronchiole, then respiratory bronchiole. Respiratory bronchiole is going to open up into the alveolar duct, and alveolar duct is surrounded by a bunch of alveoli. So this patterning, this growth is regulated by fibroblast growth factor. So if they ask you why exactly this respiratory diverticulum continues to branch out, right? So why is it branching out? This is regulated by the fibroblast growth factor. So not 8, yeah, because 8 is in the tail. Just fibroblast growth factor regulates this entire process. Now, this is important. They're going to ask you if you pick this topic. So different periods of maturations. You have to know the weeks. Just choose like until 16th, until 26, right? Birth and then childhood. Just choose like one, it will be enough. We have pseudoglandular, canalicular, terminal sac, and alveolar period. So what is it trying to tell you? Majority of the proper mature alveoli are formed from 8 months to middle of your childhood. So when you're born, you're still making more and more alveoli. So this is why physical activity is very important for children. The more they run outside, the more they do some kind of sports, the bigger their lungs will be, because alveoli are still forming. Okay, so they're still dividing there. So this is important. So only 8th month, this is when mature alveoli are actually going to be present. Until then, as you can see, from 26 until birth, you have something which is primitive alveoli. Primitive alveoli consist of 2 types of the epithelial cells, as you remember, right? So we have the type 1 alveolar cell, type 2 alveolar cell. You remember the differences between them, right? So type 1 alveolar cell is responsible for what?
Secretory cell.
That's type 2. Type 1 alveolar cell is the blood-air barrier, right? So it's supposed to participate in that. Type 2 alveolar cell is the secretory cell. It is secreting surfactant. Surfactant, as you remember, is going to be coating your inner part of the alveoli to make sure that they can expand without friction, because air and blood, right? So in the alveoli, there are lots of capillaries. So air and blood creates lots of friction. So to make sure that you can expand without the friction, that's where surfactant comes in. When the surfactant begins its production? End of month 6. Okay, so month 6, this is when you are only starting to make surfactant. This is why majority of premature babies, majority of them, the ones that are born before their time, right, suffer from RDS, respiratory distress syndrome. Respiratory distress syndrome is, as I said, one of the most fatal thing for premature babies, because premature babies can't breathe outside. There is not enough surfactant. There is a friction between the air and the alveoli. So this friction causes alveoli to collapse. And if they collapse, you're basically suffocating, right? So you aren't breathing properly. There is a hypoxia. You will die from suffocation, basically. How can we prevent this? Nobody knows why. But if you give cortisol to a woman in the premature labor, so she entered the labor, that's it, it's before her due date, right? She entered the labor. and it's too early. If you inject her with cortisol, for some reason, it quadruples the amount of surfactant in the embryo. So nobody knows the mechanism, nobody knows how, but if you inject cortisol to mom and she's in the premature labor, she's given birth to a premature baby, it quadruples the amount of surfactant production in the baby itself. So it kind of reduces the risk of the RDS. But of course, nowadays the medicine is wonderful. There are even artificial surfactants that can be injected right into the tracheal region of the newborn. So nowadays, RDS is not as fatal unless you're in the third world country where you don't have the access to the artificial surfactant. Okay, so very good topic. Branching is from the anatomy, right? So you can understand this. Larynx and pharynx, you remember that this is fourth, sixth, right? So larynx, pharynx, fourth, sixth aortic arches. You just have to mention the anatomy of it and just say the fourth, sixth aortic arches are responsible for all of it. And that is your respiratory system. Okay, guys, that's it for today. Thank you so much for joining, participating. Okay.
Thank you, Yuliya. And also, you said that you are gonna send some like YouTube videos to us.
Yes,
Thank
yes,
you.
I'm going to do it now. Thank you for reminding me because my brain is everywhere. I will do it now. Yeah,
Thank you.
you're welcome. Okay, so thank you guys, and I'm going to see you tomorrow. If it is okay, because it's usually just the three of you anyway. Is the morning okay for you guys or no?
Yes, early mornings I prefer.